Hi, good evening. Thank you so much for joining us. My name is Carla Sepulveda. I am the Director of Breast Imaging at the Lester and Sue Smith Breast Center, and I will be joining Dr. Matthew Ellis this evening for a presentation. I'd first like to welcome all the attendees and physicians from Latin America, Middle East, and the United States that are with us this evening. I'd like to say muy buenas noches and ahlan wa sahlan. We're very pleased that you're here, and we are particularly excited that this is our inaugural event. As part of our mission to promote medical knowledge through educational programs, the International Center at Baylor St. Luke's, in collaboration with Baylor College of Medicine, is honored to host the first international virtual roundtable to our network of physicians, medical societies, and the international medical community. This evening's topic, neoadjuvant endocrine treatment in the era of SARS-CoV-2. The format for this evening, I'll first introduce Dr. Ellis, then he will do about a 20-minute presentation. And at any point during the presentation, please submit any questions you have. Those questions we will follow up with at the end of the presentation with a virtual roundtable. So we will move forward, and I will go ahead and do an introduction of Dr. Ellis. It's a privilege for me to get to work with Dr. Ellis. Dr. Matthew James Ellis is a physician scientist who completed his training at the University of London and the University of Cambridge. He is currently the director for the Lester and Sue Smith Breast Center at Baylor College of Medicine and the associate director for Translational Research at the Duncan Comprehensive Cancer Center. His research focuses on estrogen receptor positive breast cancer. He has championed neoadjuvant endocrine therapy as a non-toxic alternative to chemotherapy for promoting breast-conserving therapy in postmenopausal women with ER-positive, HER2-negative disease. Dr. Ellis also developed the Ki-67 proliferation marker-based Preoperative Endocrine Prognostic Index, what we call PEPI, that was published in the Journal of Clinical Oncology in 2017. That is currently undergoing a large validation study known as the alternate study. These clinical studies have provided the context and tumor specimens for seminal investigations into ER-positive breast cancer somatic genome with insights into clonal heterogeneity, new tumor suppressor genes specific to ER disease, and new therapeutic targets. This past December at the San Antonio Breast Cancer Symposium, Dr. Ellis was honored with the prestigious Brinker Award for Scientific Distinction in recognition of his pioneering work in breast cancer research and treatment. Welcome, Dr. Ellis, and thank you so much for your time.
Thank you, Carla. I think we're all faced with considerable challenges right now, and I hope what I'm going to describe to you will be helpful as you're navigating your way through this incredibly difficult time in clinical medicine. So what we thought we would talk about today is the management of patients with hormone receptor positive breast cancer who are faced with the need to undergo surgical therapy and adjuvant treatment with at times limited availability of operating rooms and surgeons as the hospitals struggle to cope with the SARS-CoV-2 or COVID-19 epidemic. So we've been working as a consortium to try and come up with some guidelines as to how neoadjuvant endocrine therapy could be used in this population so that their delay to surgery is safe. And in fact, the patient may even experience some significant benefits of neoadjuvant endocrine therapy. So we had a few questions going into this analysis I'm going to describe to you. If we're going to delay surgery and give endocrine drugs for an indeterminate period of time until surgery becomes available, the question is this safe clinical practice? Could this even be a good thing for some patients as their tumors will regress and lesser degrees of surgery will become possible, or we might be able to identify extremely responsive patients in whom chemotherapy might be unnecessary? But on the other side of the coin, who are at risk of early progression? Are there patients with ER-positive disease who in fact should get immediate surgery or chemotherapy because they're very unlikely to respond? What about younger women who are premenopausal at presentation of their hormone receptor positive disease? And are there groups of patients in whom you're not quite sure whether delays in surgery and neoadjuvant endocrine therapy are appropriate? So perhaps they need to be monitored on treatment more closely. And if you're going to monitor them, what's the best way to monitor these patients? Say a large number of clinical investigators interested in neoadjuvant endocrine therapy. We drew on some experience of neoadjuvant endocrine therapy that we've established over the last 20 years. And I wanted to sort of first point out just some data for some trials I was involved in that I think is useful here. When we first think about neoadjuvant therapy of any type, the object is to downstage the tumor and to improve the rate of breast-conserving surgery, or occasionally, if the patient is considered inoperable, to improve operability. But of course, this is not potentially the only benefit of giving neoadjuvant endocrine therapy. Since you're giving a drug, you can monitor the response to that drug, and patients who are highly responsive should do better than patients who are showing signs of early clinical resistance. And with this in mind, we developed a model based on post-neoadjuvant endocrine therapy characteristics that included standard anatomical features such as pathological tumor size and nodal status, combined with biomarker features, particularly the Ki67 level in the tumor, which had been shown is dramatically suppressed in many patients receiving neoadjuvant endocrine therapy, as well as ER status, not only at baseline, but in the post-neoadjuvant setting, because we found that some tumors had highly altered ER status, and we were curious to know whether this was prognostic or not. And through this trial that was conducted in the late 1990s and early 2000s, the P024 trial, we developed this model called the Preoperative Endocrine Prognostic Index. Now, this trial was very interesting because it was the early days of aromatase inhibitors. It wasn't exactly clear whether aromatase inhibitors would be better than tamoxifen. But unquestionably, in this P024 trial, the aromatase inhibitor letrozole was markedly better than tamoxifen, both in terms of tumor regression, promoting breast-conserving surgery, and also suppression of the Ki67 index. And that's really why almost every trial since then has used an aromatase inhibitor rather than tamoxifen in this setting of postmenopausal women with locally advanced breast cancer. So the
Sorry to interrupt you. Yeah, are you sharing your presentation?
Oh, I may not have hit the share button.
Just want to make sure that's projecting.
Okay, let me share. Can you see it now?
Yes.
Couldn't see it before. Okay, well.
And then go into the presentation mode so it can go. There we go.
Okay, well,
Are you able to advance?
Let me just no, okay. Well, let me just start again because I think I've really only given introductory remarks here. So as I was discussing the issue of
presentation mode, so it can go. There we go. Are you able to advance?
Let me just so I can hear talking. Let me just start.
That's okay. That's just the playback. You're good. Go ahead.
Okay. All right. So for everyone. So we're discussing neoadjuvant endocrine therapy in the setting of SARS-CoV-2, which is creating delays in patient management. So I think you can see the slides now. So The question is delaying surgery and giving an endocrine drug whilst the surgical issues are being sorted out in the hospital until hospital conditions improve, is this a safe clinical practice? In fact, could this be a good thing for some patients? But are there other patients in whom this is a very inappropriate approach, who are at risk of early progression because they don't have hormone-sensitive disease despite the expression of estrogen receptor? What about younger patients, and who should be monitored more closely, and whom can be safely given this treatment and avoid the hospital for a couple of months until things improve? So as I was saying earlier, there's lots of evidence that neoadjuvant endocrine therapy is a good thing for some patients. It certainly downstages the tumor and improves the rate of breast-conserving surgery. But the other thing about neoadjuvant endocrine therapy is you're monitoring the patient's response to their most important systemic therapy, namely the endocrine drug. And by looking at the degree of responsiveness of the tumor, and you can actually determine whether the patients can be safely managed with an endocrine drug, not only in the short term, pending surgery, but in the long term. In other words, this is all the adjuvant therapy they really need. And looking at this problem over the years, we developed something called the Preoperative Endocrine Prognostic Index. And basically, this looks at the tumor not in the baseline specimen, but in the setting of the surgical specimen, which would have been treated with an endocrine drug for 4, even 6 months. And in addition to the standard pathological features, the size and the nodal status, we also found that the degree of suppression of growth as measured by the Ki-67 and the ER status were important independent prognostic factors. In other words, for ER, some tumors lost ER expression, and we found that that obviously was not a good thing for the patient's outcome. So this is what the Preoperative Endocrine Prognostic Index looks like. But if you put these factors together, you can see that there's a group of tumors which are T1 or T2, so less than 5 centimeters. The tumor is node negative. The Ki-67 is expressed in that surgical specimen to 2.7% or less, and the tumor is persistently estrogen receptor positive. Those patients are called PEPI-0. And in the neoadjuvant endocrine therapy setting, that's the sort of equivalent to a pathological complete response, because as I'll show you in a minute, these patients do extremely well if they have those characteristics. They also can do relatively well even if they have up to 3 points on their PEPI score. This is not an absolute thing. Obviously, the extreme responders do best, but as long as there's suppression of Ki-67 or the pathological features are favorable, the patients can still have an intermediate to good prognosis. So this trial was conducted in the the late 1990s, early 2000s, and sort of set the scene for a lot of subsequent trials. But because letrozole was more effective than tamoxifen in this study, the aromatase inhibitor became the favored approach to neoadjuvant endocrine therapy treatment. So here's how the PEPI-0 status is calculated. The importance here is that there's obviously a very close correlation between the degree of response of the tumor and the patient's long-term outcome. And so when we're thinking about neoadjuvant endocrine therapy, this becomes a very important principle. The other thing, though, that we became concerned about is that while some patients obviously do very well and have a PEPI-0 score or low PEPI scores at surgery, other patients weren't doing so well. And we were uncomfortable about leaving patients for 14 to 16 weeks on neoadjuvant endocrine therapy when the patients might not be responding adequately. So we developed this idea of doing an early on treatment biopsy at 2 to 4 weeks to recheck the proliferation index, to check that the tumor growth had been arrested by estrogen deprivation. And modeling on an earlier study called the preoperative letrozole study, we came up with the idea that a 10% cut point would be rather useful. And you can see in this trial, if the tumor was growing despite the aromatase inhibitor at 2 to 4 weeks. And that's the broken blue line. These patients are not doing so well as the patients in whom the proliferation index was suppressed to 10% or below. And in terms of the duration of neoadjuvant endocrine therapy, you can see from this Kaplan-Meier curve that in a sort of 1 to 2 year time frame, if the Ki-67 is below 10%, and very often it's closer to 0, within that first couple of years, there are almost no events. And so in that same trial, we're also able to validate the PEPI-0 status. Here's all patients. PEPI-0 are in yellow, and the non-PEPI-0s are in the dotted blue line. You can see that basically the chance of having a breast cancer event, if you have a highly endocrine therapy responsive tumor with suppressed Ki-67 and a pathological stage 1 or 2A tumor, the patients basically are fairly protected from any kind of breast cancer relapse. But if the tumor's growing despite the endocrine drugs or has higher stage, obviously patients don't do as well. So how is all this relevant to our current conundrums as to how to manage our patients when surgical availability is limited? Well, here, Mitch Dowsett in London at the Institute of Cancer Research played a huge role putting together a large team who examined this question of who should be prioritized for early surgery despite having ER-positive disease, and who should indeed be treated with neoadjuvant endocrine therapy, not only because it helps the OR scheduling issue, but because in fact the patient will experience benefits, both in terms of identifying endocrine therapy sensitive disease, as well as reassuring the patient that they're not going to be disadvantaged by a delay in surgery of up to 6 months. So basically, we're all invited to this particular event because we brought data sets to the table. And so data from over 6,000 patients in 6 trials of neoadjuvant endocrine therapy was examined, plus some audit data from the University of Edinburgh with Mike Dixon. So the trials here were the POETIC trial, the PALET trial, a trial looking at anastrozole plus or minus gefitinib, the ADAPT trial, mainly looking at postmenopausal data getting aromatase inhibitor. I'll talk about the premenopausal and tamoxifen issue at the end of the talk. Z1031B, which I described to you, which compared anastrozole, letrozole, and exemestane, and also some data from the alternate trial of anastrozole, fulvestrant, or the combination. This particular trial is about to be presented at ASCO in a couple of weeks. And here are the main findings. You can use a ER and PR status to identify patients who are highly likely to be controlled on neoadjuvant endocrine therapy. And I'll discuss the thresholds in a minute, but if the tumor has lower levels of ER and or PR, there's a much lower chance of clinical response. If you're going to monitor patients using that on-treatment Ki-67 value, which in the biopsy can be taken in a fairly wide window, but certainly in the 2 to 4 week window, if they're ER-PR positive, highly ER-PR positive, there's a very low chance of having a Ki-67 level that's unacceptable on treatment of above 10%. But again, if the ER-PR levels are low, there's a much higher chance that the Ki-67 will be high and the patient is at risk of early local or systemic progression. The 10% cut point is recently validated in a pretty large study by Mitch's group called POETIC, which was actually a window of opportunity study. In POETIC, if the 2-week Ki-67 was 10% or less, the recurrence risk was 7.2% at 5 years versus 19.6% if the Ki-67 was above 10% at 2 weeks, almost exactly replicating what we found in the Z1031 trial. And in the alternate trial, which we're going to see in its complete form at ASCO, we were able to present this important finding here. where in 1,299 patients, if the 4-week T67 was less than 10%, the risk of clinical progression was 2%, of which about half were confirmed radiologically over a 6-month period. So in other words, this 4-week T67, if it's low, really does reassure the patients at low risk of both systemic and local progression. So let's try and divide the patients into sort of 3 categories then. A category where you absolutely wouldn't want to give neoadjuvant endocrine therapy, despite the COVID-19 issues. Got to take that patient to chemotherapy or to immediate surgery. A group in which you can be fairly hands-off. The ERPR is really high, and the chance of them being a great responder is sufficiently high that maybe that T67 at 2 to 4 weeks is unnecessary. And then a group in the middle where close monitoring is required, and this T67 on-treatment approach might be appropriate. So this is what the algorithm ended up looking like. So postmenopausal women, ER positive, HER2 negative are the population. Obviously, that's the commonest presentation of breast cancer. If you look over on the right, these are patients that we're pretty confident that you can use neoadjuvant endocrine therapy, and you probably don't even need to do the on-treatment Ki67. In other words, if the ER is high and the PR is high, then that's a group in whom we can just go ahead and give neoadjuvant endocrine therapy and not worry about an on-treatment biopsy. Unless, and that's that little asterisk there, if the Ki67 is actually high above 30%, we might consider a biopsy. And in this first algorithm here, we're using the ALRED score, but I'll come back and give simple percentage scores in a minute. Over on the left, if the ALRED score is less than 6, those patients are not eligible for neoadjuvant endocrine therapy and should go to surgery or chemotherapy. Now, if you've got intermediate scores where the ALRED is 6 or 7, or the PR is marginal, as you can see in the middle here, you can start neoadjuvant endocrine therapy and consider the 2 to 4 week biopsy, particularly if the baseline Ki67 is high. Here, the Ki67 high meaning greater than 15%. You can consider the 4-week biopsy there. If they're suppressed, go to neoadjuvant, continue neoadjuvant endocrine therapy. And if they're not suppressed, you can go to a surgery, knowing that you delayed surgery no more than 4 to 6 weeks, which probably doesn't affect their outcome. If we try and simplify this still further, because of course, not everybody uses the ALRED score for hormone receptor levels, and we use simple ER percentages, this is what it looks like. So over on the right, you get your pathology report back on this patient with a palpable breast mass, and it's ER greater than 90%, PR is greater than 10%. That's group 3. Those patients can get neoadjuvant endocrine therapy for 4 to 6 months, unless the T67 is surprisingly high, in which case you might want to consider an on-treatment biopsy. On the left, if the ER is 40% or less, or the PR is less than 10%, those patients have weak positive hormone receptors and should go to surgery. And again, we've got this algorithm in the middle that looks complicated, but as you go through it, it's not that complicated. Basically, if the PR is positive and the ER is reasonably positive, but they're not super positive like the ones on the right, you can start neoadjuvant endocrine therapy and consider the on-treatment biopsy as a way of being absolutely sure that you're doing the right thing. Of course, this whole algorithm is going to be retested in the alternate trial, and you can see that this trial's got this built-in early biopsy here at week 4, or in some patients there was further monitoring at week 12. And I can tell you that the later biopsy wasn't that helpful. Found very few patients who were in response at week 4 who weren't in response at week 12. So I don't think a second biopsy is going to be necessary. But if the Ki67 is suppressed less than 10% in this large study, the risk of early progression was only 2%. Obviously, we'll use this trial as a big validation set for the approaches that have been presented here. So the points to remember, I think, that the algorithm we're presenting is valid only for postmenopausal women. There's too little data in premenopausal women for the algorithm to be formally evaluated. Although I would say, as long as you use ovarian suppression plus an aromatase inhibitor and monitor the patient closely, and the patient had strongly ER positive, PR positive breast cancer, I'd be reasonably comfortable with the approach, particularly if the situation in the hospitals was particularly challenging. The guidance obviously must be considered in conjunction with clinical factors. So, for example, a 90-year-old with weak ER positive breast cancer, it would be better off to treat her with neoadjuvant endocrine therapy than expose her to the hospital, given that the mortality for COVID-19 is particularly high in older patients. So better an endocrine drug than nothing is what I would say. The Ki67 methodology is really important, and there's several publications on this, which are included on the slides. And it's important to read those and share those with your pathologist as you use these approaches. But the methodologies and the Ki67 assays are pretty accessible in most medical practices these days. Now, this paper is in press for rapid publication at NPJ Breast Cancer, and hopefully within a week or two, this will be available to you. So in answer to the question, I think this is delaying surgery and giving an endocrine drug until hospital conditions improve is definitely safe clinical practice in strongly PR positive tumors and in postmenopausal women. I think that if you're concerned because the hormone receptors are a little lower or the baseline Ki67 is a little higher than you're comfortable, then you can do the on-treatment biopsy. This is actually a good thing for some patients. If they achieve a PEPI 0 response, you can be fairly confident those patients don't need chemotherapy. And obviously, for this to be, if you like, endorsed by guidelines, we need the long-term results from the alternate trial as well as other studies. But I think at this point, given the difficulties we're faced with, I think the data is good enough in the current circumstance to consider using the PEPI score as a way to guide further adjuvant therapy. I think there are patients at risk for early progression, those with low ER positive and PR negative disease and high levels of Ki67, particularly those who have high levels of Ki67 on treatment. And those patients should be taken to surgery as soon as possible or given chemotherapy. And we'd love to get more data in premenopausal women. Now this is possibly an opportunity, and case series at least could be achieved during this difficult time. And in terms of the best way to monitor, I still think that the biopsy, even though it takes another trip to the hospital, is probably the most accurate way to do it. The biopsy at 2 to 4 weeks and the Ki67 analysis. So lots of people to thank, most of all the patients, their families for participating in the trial, the many investigators involved, particularly Mitch Dowsett for pushing this paper out and collaborating with us all, the funding for many of the trials that we've executed, and I'll take any questions there are. Thanks for listening.
Wonderful. Wonderful. Thank you so much. It's, it's really interesting. I know so many of us work in multidisciplinary teams, and, on the imaging side, we all had to come up with our algorithms of who we could see and who we would delay care for. And just as our surgical colleagues did as well. So it's really interesting to see. Something I've particularly enjoyed in this difficult time is that need to collaborate with the oncologists and the surgeons to create protocols to make sure we're still able to take care of those patients that really need the care more immediately, but also finding the ones that we feel comfortable and that we can reasonably and feel safely hold off on treatment in a safe way. So,
well, I don't think you're holding off on treatment by starting them on endocrine drugs in the right setting.
That's well put. You're right.
Right. We're really trying to make sure that the right patients are getting the neoadjuvant endocrine approach.
Yes. Okay. Well, so I mentioned at the beginning, please, if there's any questions, we would love for you to submit them. We did have a few that were submitted ahead of time. And so what I'd like to do is start with those, and then perhaps others might come in while we're going through these. So the first question was submitted by Dr. Enrique Bargallo, the oncology breast surgeon, head of breast cancer department at the National Cancer Institute in Mexico City. So he submitted a couple questions. First is the current status of available genomic signatures in the clinical utility for neoendocrine approach.
Right. So, this is being examined currently, but basically if the patient has a favorable genomic signature, and there are a number, I won't pick any one particular one out, but if the patient has a favorable genomic signature, then obviously that increases as well your confidence that giving neoadjuvant endocrine therapy is appropriate. Of course, all the algorithms we've used in this setting involved these Ki67 based parameters, because of course that provides the widest availability, if you like, regardless of ability to pay for patient access. But I think there are a number of papers in the literature describing patients who have low genomic scores being appropriate for neoadjuvant endocrine therapy.
Okay, the second question was minimum recommendation in the response evaluation, time and how, de-escalation in the next local and/or systematic approach, near future in the choosing patient/responder timing in the next treatment.
Well, I think what's being looked at here is how to manage the individual patient, and I think that's where the on-treatment Ki67 is proving so valuable. So if you had an ER/PR positive tumor and the patient had an on-treatment Ki67 of 10% or less, the data is showing the risk of progression over a 6-month period is less than 2%. And if you looked at the systemic relapse rates for patients in that category, it was very low. So I think that these are really useful things to be out of the patient, because obviously the patients are very alarmed, they're expecting surgery, they're expecting dramatic things to happen to them, and you're saying, take this pill while we're waiting to sort the hospital out. And in the right patient, you can absolutely reassure them that's an okay thing to do, based on pretty large data sets at this point, involving a few thousand patients. So that's valuable. Now, obviously, what the right thing to do for patients who aren't responding so well is actually a very interesting and difficult question, because in our initial looks at this, neoadjuvant chemotherapy in these postmenopausal women with resistant disease is not that chemotherapy sensitive either. So that's kind of difficult. And I think most of these patients will probably go to surgery, early surgery.
How did you find, how many of these conversations did you have to have with patients over the past 2 months?
Well, quite a few. I mean, it's basically, it's been hard to get patients in, particularly in the first phases when the hospitals were expecting a huge wave of patients.
Yeah.
Here in Texas, we're expecting really to look like New York. Now, luckily we weren't. And so the delays in surgery, if you can call it a delay in surgery, haven't been that profound.
Mhm.
But this is an approach that would be entirely appropriate for a smaller ER-positive tumor that you couldn't even palpate, that have been picked up perhaps by mammography. So you know, I think we've all been having these conversations with patients. It's a global problem.
Yeah. Okay, I have another question that was submitted previously, but a few questions are coming in online, so I'm going to hop to a few of those. For how long, ideally, do you recommend the neoadjuvant hormone therapy in A, premenopausal woman, and B, postmenopausal woman? In what moment do you evaluate the response to see if it is working?
Okay. Well, as I said earlier, most of our data is in postmenopausal women. I'll get to the premenopausal women thing in a minute. But in postmenopausal women, personally, I think the most accurate evaluation is that on-treatment biopsy, even though the patient has to come in. If you're going to do a mammogram or ultrasound, you'd still have to bring the patient in. Right. So I think that, and the advantage of the Ki-67 assay, it's very close to when you're starting the patient on this clinical course. It's within 2 to 4 weeks. Typically, if you were going to do an evaluation by radiology, you'd be looking at 3 or 4 months. So that might be you know, too long. The patient actually could be progressing at that point because perhaps the patient, for some reason, had endocrine therapy resistant disease. Sometimes you can see it, even though the tumor's strongly ER/PR positive, as I was trying to describe, you know, with a higher baseline Ki-67. I mean, the heterogeneity of the disease is mind-boggling, right? But of all the things we've tested, the on-treatment Ki-67 is the most accurate at predicting local progression / systemic progression. So I think that's the safest thing to do if you're unsure. But as I was trying to describe, if there's a low baseline Ki-67 and the tumor's strongly ER/PR positive, probably the on-treatment biopsy is not necessary. Just put them on the drug and see them in a few months when it's safe for them to come to the hospital.
Okay, and did you want to hold
women, we don't have enough data, but if you're really forced into it, I do ovarian suppression plus an aromatase inhibitor.
Okay, I'll go back to the other previously submitted, and this was submitted by Dr. Mario Leon. He is oncology breast surgeon, Clínica Ricardo Palma in Lima, Peru. And his questions are, which patients are probably not ideal candidates for neoadjuvant endocrine therapy? Do you want to answer that first, and then I'll go for, there's a couple other questions.
Okay, so maybe it's a good opportunity to share my screen again because these algorithms are kind of complicated to look at. But I mean, he's basically asking the question we were trying to address here. So let me see if I can get that up again. And this is probably an algorithm using the percentage ER and PR scores rather than the all-red score, which is not universally adopted. So
these algorithms are what will be published in 1 to 2 weeks?
Yes, exactly. Okay. So, okay, so here's, in the big blue box, it said postmenopausal, all right, because that's where the data is coming from, studies of postmenopausal women. It's not that you can't apply these principles to premenopausal women. I would just be more cautious and obviously orientated to what's best for the patient. But you can see, the first question is, who absolutely shouldn't you do this for? And these are weakly ER/PR positive tumors, right? Those are very unlikely to be in a situation where the patient is going to be doing well. The Ki-67 is going to be is suppressed, and the patient's not at risk for local or systemic progression. So if the ER is 40% or less, or if the PR is negative in a setting where the ER is low, then I would be very cautious about giving neoadjuvant endocrine therapy. I mean, if you're forced into it because there's nothing else you can do for the patient, you know, you can go ahead. But I think that what we're trying to do here is trying to work out if he needs to go to surgery or not under difficult circumstances. because after all, if they had triple negative disease or HER2 positive disease, we would be giving chemotherapy or surgery. Over on the right, you can see these are patients we're pretty comfortable with giving neoadjuvant endocrine therapy, maybe without even Ki-67 monitoring. You can see if the ER is highly positive and the PR is positive. As long as the Ki-67 isn't crazy high, you can give neoadjuvant endocrine therapy for up to 4 to 6 months. And then there's the middle group, which we're struggling with. And this is where we're using a composition of either low ERs or PR in conjunction with ER to decide on who you can start neoadjuvant endocrine therapy, but consider on-treatment biopsy to make sure they're in response. So that's the 3 group that I'd have him consider. Does that make sense?
Yes. And how often are imaging studies needed to assess response in NET?
Neoadjuvant endocrine therapy. I know when we did these studies looking at imaging, mammography for monitoring or ultrasound for monitoring, they never held up in multivariate analyses of survival. In other words, the tumor shrank a little bit on the ultrasound. That wasn't prognostic, actually. It was always the Ki-67 that won. And I think, to me, that's a strange result, which I had it took a while to get my head around. But I think what's happening in these tumors is you've got competing clones. All the cells aren't the same. When you're giving the drug, some of those cells, they stop growing, and those clones start to disappear. But unfortunately, some of these tumors, there's a clone that's not responding well, and it starts to grow, right? And you see that with the Ki-67. But for that clone to actually get to be big enough to start expanding the tumor might take months, right? So you're measuring response at the molecular level, actually the single cell level, whereas an imaging technique looks at the sort of sum of all those cells, billions of cells getting bigger or smaller. So that's the beauty of the Ki-67, is that it's a very rapid look that you're on the right path for the patient. And imaging, useful for surgical decision-making, obviously, but not really for monitoring, as it turns out. Oh, it's obviously reassuring, but for any of these patients, we've just done physical exams to make sure the tumors, are regressing. And if you're worried about progression, you could obviously do some imaging. And mammography was particularly confusing because, as you know, Carla, you can have a lot of calcifications and a lot of architectural distortion, but when you operate on the patient, there's less tumor there than you would have thought. There would have, these patients can have path CRs. You're just looking at scar, right? So the imaging not so helpful.
I might just as a side note, as the breast imagers say that it has been demonstrated that breast MRIs are more accurate in assessing response to therapy than mammograms or ultrasounds. Just a side note, but MRIs in the middle of COVID is a big challenge in itself and an expensive tool. Role of re-biopsy to measure response. I feel like you've covered that. Do you want to add anything? Response, Ki-67 size, role of re-biopsy.
Yeah, I think I've gone through that. I mean, I think the repeat biopsy, obviously it's not ideal to bring the patient in, but a biopsy procedure, I don't know, in your hands, Carla, takes like 15 minutes or so. It's not putting a patient in an operating room, and it's probably not so different in terms of the exposure risk as doing a mammogram or an ultrasound. So I think that's reasonable. But what I'm trying to do is give you an algorithm where you don't have to do that in everybody, right? And I think that's the value of what we did. Actually, if you look at the average percentages, maybe we can go back to the slide again. But if you look at the sort of percentage of patients who are going to need a biopsy according to the algorithm, it's probably no more than, a third of the patients need the repeat biopsy. The group 3 patients, which is actually the majority of the patients, probably don't need an on-treatment biopsy. You can start the drug and be fairly confident that they're going to do okay.
And Matthew, just a question. What percentage of patients fall into the group 3?
who don't need the on-treatment biopsy.
Yeah. Is that the majority or?
2/3.
2/3. So
Yeah,
awesome.
majority of ER positive breast cancer is also PR positive, and it's strongly ER/PR positive. It's the driver of the disease.
Yeah.
Some tumors have this sort of luminal B or more resistant characteristics. The hormone receptors aren't quite as high. The PR is not always positive. The Ki-67 can be high at baseline. And they're the ones that I think we need to monitor carefully with this biopsy approach, despite the difficulties. And then there's obviously the patients who've got ER/PR low tumors. You just don't give neoadjuvant endocrine therapy to those patients. And of course, you're desperate because you can't do anything else. And surgeries or chemotherapy is just not possible.
Yeah. I'm very excited to see we're getting several questions in here. So I'm going to start going through some of those. This is from Dr. Gerardo Casarena. If a patient is not responding, would you recommend changing the drug or going into surgery?
That's a great question.
Mm-hmm.
The bottom line is that I would recommend going straight to surgery, or if you were struggling, to chemotherapy. The reason for that is what we're looking at here is intrinsic endocrine therapy resistance in the main. The tumor is just somehow wired not to be that responsive to endocrine drugs, even though they're ER positive and even PR positive. Some of those tumors are still resistant. Mm-hmm. And that form of resistance, as we'll actually show in alternate, is pan-endocrine therapy resistance. It doesn't matter which endocrine drug you use. There's no difference between them. They're probably resistant to all of them.
Interesting.
Relative resistance. Sometimes the Ki-67 is coming down, but it's not coming down to the 0 or less than 2.7% region, suggesting there's some intrinsic resistance mechanism whereby the endocrine drug is somehow meeting a block to full efficacy. And that's true for all the endocrine drugs. Interesting. So, you know, going to fulvestrant would be an appealing thing to do. I just don't think it'll work. If they're resistant to AI, they're probably going to resistant to the fulvestrant as well. Although that's an interesting question that we'll probe more in the alternate trial to see if there is a group which are resistant to AI but sensitive to SERD. I think from today's clinical practice, you have to assume that they're resistant to all of them. So you'd have to take the patient to surgery or give them chemotherapy, or ultimately both, I guess.
Gotcha. Okay, a question from Robin Shaw. Is presenting clinical stage an issue when selecting patients for NET?
Well, in our earlier studies, it was truly locally advanced disease. That P024 trial, the eligibility criteria was they were not eligible for breast-conserving surgery, right? So a lot of big cancers. And a lot of those big cancers, despite the fact they're big, a 5 centimeter, 6 centimeter tumor, they're still responsive. I mean, we all know this scenario. The patient has avoided the doctor, for several years with a growing breast mass. And finally, the daughter says, don't you think you should look after that? Well, that's a pretty slow growing cancer, and they can be very responsive to neoadjuvant endocrine therapy. And the tumors that are not are the patients that present with a mass and say, look, my breast was normal 4 weeks ago, and now I've got a mass. That kind of trajectory is typically, has a high Ki-67 index. It's triple negative or HER2 positive. But a lot of these ER positive tumors have a much more indolent biology and are perfectly well treated, even though they can be larger. I mean, it's all a question of taking the history and getting the circumstances of the patient's situation right in your head as you make the decisions with them.
Okay, a question from Mario Gianelia. Hope I pronounced that right. Is there any role for Oncotype test? You mentioned this a little bit in the talk.
Yeah, I tend not to promote one test over another because it's obviously it's a competitive world out there, and I think they're all basically pointing in the same direction. It's one approach you could take to look at to define a tumor as relatively low risk, but it's not validated as much as the Ki-67 monitoring approach, I would say. So if you want to be evidence-based, I would take the Ki-67 approach myself. But for a patient in who you absolutely knew you couldn't do an on-treatment biopsy, for example, that was in that intermediate group, then I think taking a genomic test might be a reasonable alternative, but we haven't really adequately studied that.
Interesting. Okay. Question from Eva Ruvalcabar. Hope I got that. Let's see. In post, economy is not too good because of the pandemic. In postmenopausal women, do you recommend tamoxifen as NET instead of aromatase inhibitors?
Well, that's an interesting question.
Yeah, taking in.
Well, you know, you'd have to say that something is better than nothing, right?
Yeah.
So if tamoxifen all you have, tamoxifen is a perfectly fine drug.
Mm-hmm.
Just in double-blind, randomized, dummy study, which is the P024 trial, it wasn't as good as an aromatase inhibitor. In terms of suppression of Ki-67, or in terms of tumor regression, or in terms of converting patients from mastectomy to breast-conserving surgery. So I think, given that, even though the aromatase inhibitor, which after all are already are generic drugs and don't cost a fortune anymore either, I generally would have a preference to give an aromatase inhibitor over tamoxifen. But if tamoxifen is all you have, then use tamoxifen.
Mm-hmm. Mm-hmm. I wish we had a live communication with her, because I'd love to know, you know, how the drug availability is being limited with the challenges to the economy in her country. That would be interesting to hear. I have not heard that to be an issue in the United States yet. I mean, we know that there are people who have lost insurance, large millions of people who have lost their insurance, but I don't think we have seen that trickle in terms of the patients that we're seeing. Perhaps on our county side, that will.
Yeah, in the safety net hospitals, well, I'm sure we'll start to see difficulties. But yeah, the evidence suggests that a aromatase inhibitor is the better choice. But as I said, if you're forced into giving tamoxifen, give tamoxifen, and that's all I can say really about that difficult issue.
Yes. Another question from Dr. Ronald Limon from the Instituto Oncológico Oriente Boliviano. And it is, what happens in a patient with PR positive without ER positive? Is primary surgery the best option?
Yeah, probably. If we go back to the algorithm again, this is actually kind of interesting, right? We can bring the algorithm back up as these questions come to illustrate the algorithm and look at it again.
Yeah.
So my friend is asking about tumors that are PR positive but ER negative. Well, it's ER negative, it's sitting over here, right? And therefore we're recommending surgery. Actually, truly ER negative, PR positive tumors are pretty rare. In my experience, they tend to be not even luminal breast cancers, but some mysterious form of triple negative breast cancer that can have low levels of PR. Sorry, not triple negative, some form of basal-like breast cancer that just has relatively low levels of PR. When you see PR being positive in the absence of ER, the PR level is usually pretty low and would struggle to be more than 10 or 15%. So those kinds of tumors are probably not suitable for neoadjuvant endocrine therapy, if that helps.
Yeah. Yeah. Okay. So I don't see any other questions coming in. Any closing remarks before I give some closing remarks?
Well, thanks for listening, everyone. We're here to help. We're trying to use evidence-based guidelines in this difficult time, and I'm interested in feedback. The one thing feedback I can give you, Carla, is someone thinks your Spanish pronunciation is extremely good, and you can. I don't think I could have done as well.
Oh, I have to apologize. A question was submitted to me and there was a typo and it was actually Mauricio. So I apologize. On my paper, it was Mario. So Mauricio, I apologize. So again, thank you all very much for joining us. We hope so much that you, your families, are able to stay safe and stay well during this time. I know as healthcare workers, we are all together trying to find navigating these very interesting times. And as we have surges, we have certain algorithms that are needing to come in play. And then now we're starting to open up and we're trying to find those stepwise measures of how do we open up carefully. I think a lot of us feel like at least should there be a surge in the fall, after all the work that we have all done in creating these algorithms, going forward, I think we are positioned in a much better place than we were, say, 2 months ago when this, I think, somewhat caught us very suddenly. Again, very excited that we had this inaugural event with you. For the next session, there are 3 set up already. The next one will be on May 28th at 5 p.m. and that's Central Standard Time. And that will be with Dr. Alistair Thompson. He is the head of our breast surgery program, and he will address what do I do in the axilla after neoadjuvant therapy, a multidisciplinary approach. He, similar to Matthew, has a very charming accent and is really a wonderful model of putting the multidisciplinary approach into breast cancer care. So I hope you will be able to join for that. A few thank yous before we go. We would like to recognize the Peruvian Mastology Society for their support, the National Cancer Institute in Mexico City, the oncology units of Seguro Social in Mexico City, the Mexican Association of Mastology, Hospital San Javier Medical Education Department in Guadalajara, the C. Mater Hospital in Tegucigalpa, the Semesa Hospital in San Pedro Sula, and the Hospital Herrera Yarandi Medical Education Department in Guatemala City. So wonderful to have this opportunity to reach out to all these places and to our partners. And again, we really appreciate you being with us this evening. Thank you, Matthew, very much.
Yes, and hopefully we can get together again with our friends from Central and South America soon. So thank you.
Thank you.